Welcome to the Stroke SIG Student Corner, Part 2, the examination process. My name is Heather Hayes. I'm the chair of the Stroke Special Interest Group, and I work out of the University of Utah, and I'm very excited to be here today with Jacob. Jacob, can you introduce yourself?
Yeah, hi. My name is Jacob Striejewske, and I am a third-year SPT, also at the University of Utah.
I just want to introduce you to what we are doing now in the Stroke SIG. We're trying to interact with students, get an understanding of their analysis and working with stroke patients and specific concerns that they might have. We're interested in hearing your questions that you would like to have answered. We don't have to put you on the spot. We are willing to have you be anonymous, and then we will seek some answers for you or do another video to help guide you. So we hope you will take advantage of this opportunity to interact with us and let us continue your education along the way, specifically with stroke, patients with stroke. So today what we're going to do is look at an examination process. This is a continuation of Part 1 where I hosted Lynn Johnson as a student. She was able to perform a gait analysis on a person post-stroke. The individual was in the chronic phase of stroke, and the goals were to be able to keep up with her teenage children. She didn't feel like she was able to walk as quickly as she needed to. We will be playing a clip here of the gait analysis just to review what has happened. Now we're going to head into what some of the summary findings that we found. So what we found on the analysis is Lynn was taking an approach from the toes up, and I prefer to take approach from the top down. This is really just an individual's preference. Sometimes I find, though, if I look at the ankle too soon, that I may be fooled a little bit by what I'm seeing. So I might see that it looks like they have a lot of eversion at the ankle when it may be more external rotation happening at the hip. So be sure that you should end up at the same location, whether you start from the top down or bottom up, but consider that as you go through your own gait analysis. And so the concerns that we found were that the pelvis had a mild hip hike. It was not consistent. She would utilize that hip hike when she didn't get enough toe clearance or knee flexion. But the other one that was probably more pronounced was the lack of forward rotation in the hip and the hip being retracted. The other things that were of interest is that the hip did show some external rotation in order to clear. She would either use the external rotation or the hip hiking. She could vary that depending on whether she was on a treadmill or not. And then we had forefoot contact or forefoot flat, and that was really not really a foot slap, and that's something that we want to investigate. She also does have a little bit of excess plantar flexion, just keeping it in plantar flexion through swing, and as well as a little bit of eversion. So what I'm going to do now is I'm going to ask Jacob to provide us a little bit more information on how he might choose to identify these impairments more specifically. And so Jacob, what would be some aspects of this that you want to investigate when we're just talking about these impairments that we've observed in our gait analysis?
So just generally kind of from a global view, definitely spasticity at pretty much all lower extremity joints, as well as range of motion, both passive and active, and strength if we can. And I think that will help lead us into some of those more functional impairments based on that information that we receive there.
Okay. And when you say spasticity, what are you anticipating to see with spasticity?
So I think it mentioned it at the end of the first video that you did with Lynn, but I wouldn't be surprised if I noticed increased tone in both the affected side's quads, the knee extensors, and then her gastrocsoleus complex, the plantar flexors.
Take me through exactly what you would do on the ankle. Let's go through what you would ask the individual to do at the ankle for a moment.
So at the ankle specifically, we'll have her actively plantar flex and dorsiflex, and then also invert and evert. And then after that, we'll do that passively, add some overpressure, see if there is more range of motion passively than actively. And then from there, likely go through the spasticity testing, the modified Ashworth and the Tardot.
Say that we find that she has no passive range of motion limits. And if you do velocity dependent, you find that her gastroc and soleus are a 1+ on the modified Ashworth. Okay. So no passive range of motion deficits, a 1+ on the modified Ashworth. She is unable to fully actively perform a whole active range of motion.
Okay. If that's the case, I think it's still a little tricky to determine whether or not it's a tone issue or a strength issue. I think from there, limited to 80%. I think from there, I would likely do some further, more functional strength testing at the ankle, especially if we're trying to decide if it's strength or tone, maybe something like a heel raise to kind of try to parse that out a little bit better. Yeah, it sounds like you're talking about the Fugelmeyer. That would definitely give us some insight of her synergy and, like you said, if she's able to isolate movement.
Great. So can you just talk me through just a little bit, let's assume that she has full flexion synergy, full extension synergy, and she can demonstrate those so we're out of the synergies, but now we're starting to move combined synergies. What's the test for combining synergies?
So for the lower extremity to combine synergies, if I remember correctly, she would be seated and then trying to perform full active knee flexion past the 90-degree mark, I believe is what she needs to start combining the synergies.
Okay. And I'm going to tell you that she's going to score a 1 on that. Okay. So she's unable to pull that knee all the way back under. And what we end up getting is her trying to pull the knee back with her pelvis, right? So you get that kind of cheat where they think that they're pulling the leg back, but they're not. And she only goes to, so she can sit and then she only brings the foot back to the other one, but not beyond. Okay. And then what's the part for the ankle on that test?
Part for the ankle, again, if I remember correctly, seated kind of in 90-90, and then active ankle dorsiflexion.
Okay. And again, she's going to give us a 1. So what she gives you on that is she gives you just a little bit of, it's actually not a full dorsiflexion. It's a little bit of trying to lift the toe, but it's kind of comes with a rolling of the ankle. But at least we are attempting to get dorsiflexion. So now that you've kind of seen this, so we are dealing more with a synergy, combining synergies with that mild deficits of 1+. I don't think that she has the strength to overcome the spasticity.
Okay.
Okay. And is it possible to test her dorsiflexion strength at this point and give her a score?
If she can't overcome the spasticity, I would think probably not. It wouldn't be accurate of the strength.
Okay. Okay. Let's go up to the hip. So there was a mild internal-external rotation deficit. What might you think that is from?
When you were discussing this with Lynn, it sounded like you were getting at her circumducting through her swing phase. And I think this is both a combination, or at least we need to decide if it's a combination of the increased tone in the quads, or if there's also weakness in the hip as well.
Great. Talk me through spasticity of there. Do you think she has an extension synergy or a flexion synergy tone pattern?
With the decreased knee flexion, I would be more inclined to think that she has a flexion synergy, and that's also generally most common in the lower extremity, if I remember right. So I think that helps guide as well.
So with decreased knee flexion, that means that the knee is tending to go to not bend, so therefore the quads are tight. So that would actually be an extension synergy.
Oh, it's not sure.
Yeah, okay, no worries. So tightness in the knees and the quads means an extension synergy throughout. So do you think her hip flexors, so that means what's the other thing? What's going on with her hip extensors?
They likely have increased tone.
Okay, and therefore weakness of hip flexors. Yes, so that's how we get that kind of compounding effect all the way through that limb. So most likely some increased tone in the hip. It's also, when we get back up to our pelvis, we find that it's retracted, and that's going to be tricky to tease out. But most likely all of that's coming in from spasticity. That's retracting the hip, keeping those extensors are tightening, the quad is tightening, and all of that is limiting. It's not totally rigid or anything like that, but it's just all kind of compounding and fixing her into that retracted gait, having to make these little compensations to be able to swing that limb forward. So our number one issue here does appear to be, like, we wouldn't be able to assess hip flexor strength because of the increased tone in the quads, in the glutes. Okay, all right, so we're heading more towards spasticity is most likely the issue. Very subtle spasticity, and so I think that's fine. At least we can acknowledge that we have some spasticity here, and we truly can't test strength, but we want to because we have other measures that we need to be looking at. What are we going to do with this retracted pelvis? What on earth how does one test that?
That is a great question, and I was hoping for some guidance from you for that.
Yeah, it is interesting. So when somebody's in that retracted pelvis, one thing you even try to do is watch how they scoot forward in their chair. And so you and I can actually isolate one hip forward and the other hip forward. Those techniques where you have them in a bridge position and you're trying to ask them to push that hip up, can they actually give us that hip rotation or not, that pelvis coming up? And you'll find that all just kind of does happen en masse. And when scooting forward in the chair, everything scoots forward. There's no dissociation between the pelvis on that. And so you could even, some of the things that I try to do to really understand what's going on is, because you're not truly going to get the spasticity out of this, if you put them in side lying and you even just try to do some rotation, you can start to feel if there's tightness in there and seeing what's happening at the pelvis there. And it's a great way to help them learn to stretch that pelvis a little bit and feel that. And you can even try to get them to, if you do some PNF, so pull the pelvis back and then ask them to pull forward, and have them start to be able to isolate that a little bit more. So if I was, this would not be a true test that you would want to, that you could say, you know, I see A, B, and C quantitatively, but you would note that difficulty with bringing hip into and forward when sideline, or difficulty isolating her hips in a seated posture. Okay, and this really becomes the area that I would focus my treatment on, because if I can get that a little bit smoother for her and give her a little bit more stability, not spasticity stability, but strength stability, then I think we can work down the chain.